Everyone, to our session on postpartum hemorrhage community of practice, special topic deeper dive series. A very warm welcome to everyone. Good morning, good afternoon, good evening, wherever you're joining from. It's great to have you, and it looks like we have a pretty good participation already, and people are still coming in, but we're going to go ahead and get started with our session. Many of you participated in the PPH Community of Practice virtual annual meeting about a month ago in July. And as you may recall, we talked about having these ongoing, continuing sessions that would look at essentially taking a deeper dive, look at some of these topics that we addressed in that annual meeting. And we had a survey that elicited your suggestions on what those key topics would be. And this is one of the leading vote getters, one of the leading options that came out is PPH at cesarean section, prevention and management. And this is what we're going to be looking at today with a focus on country experiences and lessons learned. Next slide, please. So the agenda for this, so it's a 90 minutes meeting that we have, and this is the general outline of the agenda. I'll start off with an overview of PPH at cesarean section. This will be drawing on the breakout session that we had at the annual meeting. Then we'll turn to the Tanzania team to discuss their experience at the country level and lessons learned. This will be followed by a question and answer period, and then an open discussion and shared learning. This is really a large portion of this agenda will be on that, where we really want to hear from countries about their experiences with PPH at cesarean section. Next slide, please. So some quick logistics. You'll see that, so this is going to be a little bit different than the annual meeting. So this is more of an open meeting, and as you get admitted, please mute and keep your video off when not talking. You're actually already muted, and you'll note that as you enter the meeting, you will be muted. And you can choose to have your video on or off. A recommendation is to keep it off when you're not speaking, and this will help with some of the bandwidth. If you elect to keep your video on, please avoid distracting movements and actions or anything embarrassing that could happen on the video. For the chat, please use the public chat for general comments or to contribute to chat discussions. If you want to ask a question to a panelist or to a particular person, or you want to share your experiences or lessons learned at the country level, please use the raise your hand function, and that's at the bottom of the, when you click on the bottom of the participant list, you'll be able to see the raise your hand. And we'll be screening for that, trying to find people that raise their hand. Please be patient with us. There's a lot of participants. And so we'll be screening through we're now approaching 80 participants, and we'll be screening through that in order to get to your questions and your ability to comment. And when you get called upon, you'll be asked to unmute. So make sure that you unmute and then turn your video on when speaking. So we want to be able to see you when you're speaking. And before you speak, please introduce yourself. Introduce yourself by stating your name, your title or role, country that you're coming from, and the organization or facility that you're associated with. And then lastly, this webinar is a safe place. It's a place for respectful discussion, and we want to adhere to that. So please do not use offensive language or comments. Great. Next slide, please. Great. So I'm going to start off with, this is a kind of a review or an update on the evidence around PPH at cesarean section, prevention and management. And this is very similar to the breakout session that I did with Professor Kumarasamy during the annual meeting. So this will give some background as well as kind of lay the foundation for some of our discussion as we go forward. Next slide, please. So the outline that for this discussion will start with looking at some of the epidemiology around PPH and cesarean section, then talk about detection and diagnosis with a focus on early detection, including postoperative detection of PPH, and then looking at management, so prevention at cesarean section as well as treatment during and after cesarean section. And this is really going to also, as we talk about this, I think it's important to not only when we're looking at different, medications or surgical techniques or, algorithms, that we, some of the things that we're, seeing is that it's important that this is embedded within teamwork and communication, and how important teamwork and communication, anticipation and planning is for effective management of PPH. Then we'll turn to the Tanzania country experience and lessons learned, and followed by a question and answer period, and then the discussion. We'll open that to the floor for discussion on sharing experiences and lessons learned. Next slide, please. So epidemiology, so definition at cesarean section, we know that at routine vaginal birth, we typically use 500 as the cutoff for PPH. Other definitions for, especially at cesarean section, use 1,000 milliliters as that cutoff. And then other definitions within that is for severe PPH is 1,500 milliliters, massive PPH is 2,500 milliliters. And as we'll see later, obviously the higher you go, on that scale, the worse your outcomes for that. And when we look at if we look at the 1,000 milliliter cutoff, we see that for elective cesarean section, that rate is around 5%, and with emergency cesarean section, it's around 7%. And so this is about 3 times higher than what we're seeing at vaginal birth. And then with severe PPH, we still have a fairly significant percentage of women who suffer that PPH. And I think the other important thing to note is that it's not just the amount of the PPH, it's the clinical kind of response to that. And so if you're starting off with a lower hemoglobin, then obviously your response is going to be much different to 1,000 than someone who's starting off at a higher hemoglobin. Next slide, please. And this is recent data from the University of Birmingham that looked at the average EBL, average blood loss at cesarean section. And this just shows that with emergency cesarean section, essentially that you're going to have about 100 milliliters greater blood loss at that. Next slide, please. And this just is a graphic in a map of the world of the cesarean section mortality. It's not surprising to see where red is the higher rates of CS mortality, and it tends to cluster in the same countries that we have kind of across other conditions. So seen a lot in sub-Saharan Africa. Next slide, please. And when we look at maternal death after cesarean delivery, it's about 50 to 100 times higher in low and middle income countries compared to high income countries. And I think the other important kind of take home from this is that 25% of all women who died in LMICs had undergone a cesarean section. And so this is really, really important points, especially when we're talking about programming, because if our maternal newborn health programming is not including cesarean section or surgical management for maternal complications, then we're really missing the boat. I mean, this is, that's a lot of women that are dying. So I think that kind of a comprehensive approach in the continuum of care is certainly important. And then when we look at the breakdown of the causes of maternal deaths, we see that PPH is the leading cause at cesarean section. Nearly a third are due to hemorrhage at cesarean section. Next slide, please. And when we look at the causes, we talk about the 4 T's, and the 4 T's still apply for cesarean section. The how it's distributed is a little bit different. Certainly, atony is still a leading cause for it. About 70 to 80% are due to severe PPH at cesarean sections due to atony. And it's due to prolonged obstructed labor, et cetera. The other is a big or increasingly important cause is tissue or abnormal placentation. And with that, we're talking about placenta previa, placental abruption, but also about placenta accreta, increta and percreta, and that becomes a more of an issue with the rise in cesarean section rates and with repeat cesarean section, especially when we start talking about the 3rd, 4th, or 5th cesarean section. Then you really run to much higher risk for these types of abnormalities. Trauma is another one, again related to laceration or uterine rupture, but lacerations and tears, especially when we're talking about, say, advanced labor or impacted fetal head, that becomes, much more challenging. There's a study by Professor Stovey that looked at this, and the risk of hemorrhage is about 5 times higher in women who had cesarean section in the second stage of labor. Next slide, please. So this, we talk about the challenges of detection of hemorrhage at cesarean section, and historically, we know that there's been a real challenge with documentation of hemorrhage, both at vaginal birth and at cesarean section. Visual estimations are notoriously inaccurate, and so there's methods that we're looking at that can better quantify that, whether that's with collection drapes or weighing of soap swabs will help better with better estimation of the blood loss. The challenge, with at cesarean section, in addition to what we have at vaginal birth, is you do have the amniotic fluid, but you also have the irrigation fluids. So capturing the fluid that's in not only in the laparotomy swabs, but in the suction tubing that's under the drapes and things along that line. So it's a real challenge, and we see this also when we're looking at the data. When we talking about the earlier epidemiology about the rates, that's in kind of research type settings. When we look at what typically is being reported, we're seeing rates of like 1% or less, which we know is not realistic, and that whether that's probably a combination of that not really detecting it or realizing that there is a PPH, or just kind of this fear of reporting PPH. So the data ends up being not very helpful if it's not such high quality on a routine basis. Next slide, please. And so we're trying to do is build the evidence for developing algorithms for managing hemorrhage at cesarean section. And this is an ongoing process. It's really kind of bringing all the pieces together of around prevention, identification, resuscitation, and then early and active management, whether it's medical management or surgical management, and essentially trying to bring these pieces together. We're getting better evidence for around this, but we currently have better evidence for preventing and managing PPH at vaginal birth than we do at cesarean section. But there are some algorithms that are being created. Next slide, please. And I won't go into detail on this, and you'll have these slides in the PDF, so you can look at this a bit closer. But this is a nice one that was developed by Professor Falkus, who I think I saw is attending this session, and it's very helpful. So being able to develop algorithms like this, I think, is really helpful for essentially for like guideline development as well as job aids, which I think is one of the challenges that we'll hear from countries when we discuss this later. Next slide, please. This is just a nice slide by Professor Weeks that looks at the kind of that continuum of the risk with the amount of blood loss, and we see that prevention obviously occurs before the blood loss, and that the importance around effective prevention, but also early treatment, because it's a slippery and quick slope down to challenges in preventing morbidity and death once we start getting to the 1500 or greater area. So that's really the importance of this early identification and active management of treating PPH. Next slide, please. So some of the methods for prevention of hemorrhage or PPH or cesarean section, it's not just about the uterus itself or around like use of uterotonics. We do know that, for example, the incision, the surgical technique is certainly important. The Joel Cohen incision is preferable to the fan steel, and especially for the midline incision. We can talk about the Joel Cohen later if you're not familiar with it, but essentially it's a transverse incision and uses more blunt dissection. And what it's shown, it does shorten the operating time, less use of suture, less blood loss, and things along that line. And I think what we've found kind of historically is that non-specialist physicians tended to be taught to do a midline incision because the belief that it was easier to do, and that is so wrong. It's not easier to do. The Joel Cohen is very easy to do, and the complications are much less. The blood loss is much less with the Joel Cohen, and recovery is much better. The other is around delivery of the deeply impacted head. Had mentioned the increased risk in the second stage, especially with a deeply impacted head. And again, I think the early training, certainly I was trained, to do vaginal elevation of the fetal head, whereas we know that it's a reverse breech extraction. It is easier and causes less trauma and less risk of lacerations for delivery for that type of condition. The other is placenta delivery. Again, there's early on there's the teaching was manual removal of placenta, but we know that with controlled cord traction, that it decreases blood loss as well as decreases infection, decreases endometritis. Next slide, please. So looking at the uterotonics for prevention of PPH at cesarean section, these are the similar uterotonics that we have for at vaginal birth. So the recommendation is oxytocin. The recommendation is 10 units IM or IV. Practically speaking, IV is going to be better. And well, we know that even from pharmacokinetics that IV is better. And even ongoing infusion for with oxytocin is probably preferable. I think we see some recommendations around IV bolus, so kind of direct bolus with that, but there's also risk of maternal hypotension. So a kind of a practical way around that could be using anywhere from 10 to 40 units in 500 to 1,000 milliliters. And you can run in, half of that, you can run in about 500 milliliters and then run the rest at 125 mLs per hour. The other uterotonic is the ergometrin and oxytocin combination. There's some consideration around the use of heat-stable carbetocin, especially where the quality of oxytocin is a concern. There are, in some contexts, using the combination of oxytocin and misoprostol. So using 600 micrograms, either sublingual or oral, along with oxytocin. There's no, strong evidence around that, but the rationale, it'd be great to hear from country experiences, is around use in those that are at higher risk, or if there's concerns around the quality of the oxytocin and you don't have other options available. The other interesting aspect is the role of prophylactic TXA, whether that's for high-risk patients or for all cesarean sections. And what it's been shown that TXA does significantly decrease the risk of blood loss, massive hemorrhage, transfusion requirements, and the need for additional uterotonics are all markedly reduced. So I think that's an interesting area for further research. Next slide, please. Then surgical management of PPH at cesarean section. So this is really talking, what we're going to be talking about next is just around uteranatomy. So when medical management of uteranatomy fails, then you need to think about surgical management of PPH. But it's also used for when other causes are present, like trauma, such as ruptured uterus or abnormal placentation. And this is also to note that the medical management of PPH tends to have better quality data than we do for surgical management. So a lot of this is based on case studies and some systematic reviews. Next, please. So PPH at cesarean section due to uteranatomy, you assess and resuscitate. So monitoring of vital signs, measuring accurately measuring the blood loss, IV fluid resuscitation, blood transfusion as needed. Medical treatment includes uterotonics, and in the box below shows the recommendation of the uterotonic. So you have the oxytocin, methergin, if that's available, 0.2 milligrams IM every 2 to 4 hours, and then the misoprostol. The thing to note with misoprostol is that sometimes you'll still see that the recommendation for birectum. I think that's really probably out of date, and it's really sublingual or oral if the woman has an appropriate airway for it, and just because of pharmacokinetics with the misoprostol. Then obviously the TXA, if you haven't used it already, then using the 1 gram IV. Then moving to surgical management. So if if medical management is not working, then making the decision early on for medical management, and ideally looking for uterine preserving methods. So this is where the uterine compression suture, like the B-Lynch suture, comes in. Next slide, please. So the keys to successful surgical management, I had mentioned earlier in the presentation, is really around teamwork and communication. I think that's is really coming through loud and clear with the research, and certainly with our programs, we're seeing that. Anticipation and planning. What complications are you anticipating, and planning for that, having the appropriate materials and team available for that. Use of the cesarean section adapted WHO surgical safety checklist. It kind of incorporates some of these aspects in it, and I think we found that that has had a dramatic improvements in our surgical outcomes. So implementing that, I think, is something has gone a long way to improving outcomes. Early identification and management according to cause, situation awareness in the operating theater, in both individual and team situation awareness. And this, again, it comes back to the teamwork and communication. And we're seeing, and the research is showing as well, that these non-technical skills are really essential for improving team performance and improved outcomes. So it's not just the the specific algorithms, but it's that teamwork that helps ensure the appropriate implementation of that. Early decision to use compression sutures such as the B-Lynch for uterine anatomy, and then the post-op care and monitoring. I think this is also tends to be a gap, and this is looking at that, preventing the failure to rescue. When we've seen from the ASOS studies, the challenges around postoperative care and monitoring in some low resource settings, and then incorporating the use of some modified early warning systems certainly can improve that as well. Next slide, please. So this is where I'm just going to finish here, just talk briefly about the B-Lynch suture. I know the Tanzania team is going to discuss more about this, but this is really a promising technique to incorporate. It's been around for like 20 years or so, but really hasn't been disseminated a lot, especially to non-specialists. The reason why it's something that should be incorporated is that it's easy to perform. It takes generally less than 2 minutes to perform, and it's easy to practice on a simulator, as well as obviously in clinical cases, but very easy to practice on a simulator, and you can just hand make these very easily. Does not require special equipment or supplies, and it is effective. If you look at the literature, generally you're going to see around 75 to 90% success rates with this. And it's the most studied compression suture, the B-Lynch. And you'll see other types like CHO, Heman, et cetera, and different modifications. But this one, it's really quite simple. It's easy to learn. And there's a graphic there. We can show a video to see how to do it. But it's really a quite easy procedure. And there's no apparent impact on infertility. So many considerations is do not use permanent suture. If you use permanent suture, then there's risk of bowel herniation or strangulation. And there are some concerns regarding risk of uterine necrosis if combined with the devascularizing sutures like the uterine artery or ovarian artery ligation. Next slide, please. Great. So the really, I think the important things from this to think about is that the cesarean section is a significant risk for hemorrhage and maternal mortality. We saw it, about 25% of maternal mortality is associated with cesarean section, and hemorrhage accounts for about 32% of those cases. And that's for PPH programs, it's essential to include surgical management of PPH and managing hemorrhage at cesarean section. We're still looking at building the evidence for the most appropriate bundles, PPH bundles and algorithms for this. Research is going on. There's look at research on risk stratification, package of evidence-based interventions, targeted post-op monitoring, and making difficult deliveries safer. And successful implementation requires the non-technical competencies around teamwork and communication is really important, and that B-Lynch uterine compression suture is an attractive surgical method and should be considered to be integrated into all programs that are providing cesarean section services. So next slide. Great. So that's the overview. And I'd like now to turn this over to the Tanzania team to share their country experience with PPH at cesarean section. And this is the Chivago team that has, that we'll be talking about our safe surgery program. But this has really been in close partnership with the Ministry of Health, with the regional health bureaus, professional associations, the facility administration. So it's a very collaborative approach for safe surgery. And I wanted to introduce Dr. Leopold, who's our technical advisor on the programs. He's an obstetrician oncologist by training. Augustino Heller, who's our project director for safe surgery, and Joseph Masenga, who leads our Barisha Afya program in Tanzania. You're a welcome team.
Thank you, John. Okay, thank you. So I'll take you through this second piece, talking about experience in the Tanzania, especially the findings from our Safe Surgery 2022 program we are implementing here. The next slide. Yeah, so a bit of background and context that in the Tanzania, the maternal mortality rate is stagnant has been stagnant for some years. Currently is around 524, sorry, with an annual reduction of 2.9. This is according to 2019 WHO UNICEF data. But it's also very important to note that PPH is a leading cause for maternal death here, standing at 29%. And according to Demographic and Health Survey, according to this health information system, this is a system capturing the indicators. A proportion of facilities receiving ultrasonic in Tanzania is around 90%. And the PPH incidence here is also about 0.8. And we have a national reproductive maternal newborn child and adolescent health strategy that indicates that there is some improvement in quality of care for the obstetric emergencies. And the graph on the right side shows the Demographic and Health Survey data, 2015-2016 indicated that our maternal mortality rate was at 556. And then as of last year, according to WHO UNICEF data, it was at 254. So you can see it has been stagnating almost around 550. Next slide. Again, looking at on the map, I think the red zone is where the maternal mortality ratio is more than 100. And on the causes, the leading is hemorrhage, then abortion, hypertension, obstetric labor, anemia, and hypertension, the fifth. But overall, the case fatality rate is very high for the sepsis and the hemorrhage. And I think that justifies that we needed to discuss around how we manage PPH and other causes of hemorrhage. Next slide. Yeah, so this is now looking at the program in Tanzania, improving access to safe cesarean section services. The safe surgery program in Tanzania focuses in the two regions around the Lake Victoria zone, in the northern part of Tanzania. The country had a national strategy to upgrade all the health centers to become CMOC facilities, and these are equipped with theater, but most of the staff are non-specialists. And almost at the same time, there was a start of the USAID-funded USAID Barisha Afya project, also expanding CMOC services in the same region. So it was well aligned with the safe surgery supported facilities. So the safe surgery program in Tanzania supports 40 sites. All these are the CMOC facilities in the 2 regions. And most of the staff in these facilities are non-specialist surgeons. These are the medical officers and the assistant medical officers. And then there's anesthesia providers, mostly majority of them are the nurse anesthetists. So we have a challenge with the workforce, as you can see. The skills are not much standardized. Before the program started, and the infection prevention bundles, the management of PPH, there was a diversity in terms of practice and approach. And these are the gaps the program came in to address. More important is the teamwork or team cohesion and the communication, reinforced much by the use of WHO surgical safety checklist from the program inception and the onset training, but continuously reinforced through the mentorship. Also, there are some challenges with the use of electronics, with some stockouts sometimes, but also TXA availability. As we shall see, it has been included in the protocol, but I think the stocking and availability and the dissemination is a challenge. Next slide. Yes, the program focuses on safer cesarean birth. It started back in 2018, and it is continuing up to date. And we focus much on team performance, and the approach on capacity building is in terms of team-based approach. So we train a team of doctors, nurses, and athletes, and they train together, and they also join mentorship together. We build non-technical skills such as teamwork and communication, because the program also focused on two pieces. The first, this team are trained on leadership skills, and then they come for the clinical skills training. On the clinical skills piece, we focus on the update on jaw incision. As John has pointed out, this is the recommended incision with less time, less bleeding, complications, and significantly reduced hemorrhage at C-section. But again, we also focus on skills on spontaneous or controlled contraction when delivering the placenta at cesarean section. Implementing the surgical safety checklist is key in this package of resource, and also we incorporate infection prevention bundles. This is a package of practice which are evidence-based, including antibiotic prophylaxis, a quarter to 1 hour before the incision, vaginal cleansing for those ruptured membranes or in labor, and abdominal skin prep, using chlorhexidine, alcohol-based, or the povidone iodine, which we see mostly in our area. Actually available is povidone iodine, and it serves the purpose. So we are integrating medical and surgical management of PPH also in this training, with focus and much attention to the B-Lynch as a fertility saving and reducing number of unnecessary subtotal hysterectomies when PPH arises, as we shall see. Next slide. Yeah, so integrating the B-Lynch suture. In our safer cesarean birth training, we review and provide updates on the medical management of PPH, including uterotonics, uterine massage, and knowing that medical managers can fail, and we had this information, although that there is a lot of, when it fails, there was a lot of hysterectomies. We have really integrated surgical management of PPH at cesarean section in the program. The B-Lynch uterine comprehensive suture in the program is first simulated in the class. You know, we start with 3 days classroom training with simulation using just simple simulators, some improvised, and then there's coaching on the practicum for 2 days in the real client. And the skills are continuously reinforced through the in-person mentorship when the mentors visit these facilities. So the procedure itself is easy to learn, and even by the non-specialist, we use improvised simulators as much as we can, and the skills can be delivered, but it's much supported by ongoing mentorship for those who cannot grasp skills at first contact with trainers or the mentors. Some of those in the right side is the photo from the clinical training. You can see the mannequins we used to train, the teams in the class, and then in the clinical area for the practicum training. Next slide. Yes, so teamwork and communication has been a cornerstone, and of the training has been insisted through the mentorship and is improving. So through some of the data from the report and the midline evaluation for the program indicated improving in teamwork and communication, as reinforced especially through the use of WHO surgical safety checklist, but again discussing around anticipations and potential complications before the surgery. So the checklist adherence has overall increased from 0. Actually, there was no use of checklists in most of these facilities. So it's now over 90% used in, and the correct use is also more than 80%. But also data shows that the perioperative mortality rate has significantly reduced by about 50%. And also teamwork and communication indicators, those discussion, team briefing before the surgery and even after surgery is quite improving. We see some also testimonies. Those are some of the quotes from providers during the midline evaluation that they now work as a team, they have skills, and individuals know that now they are aware of the role to play when they are also working in theater, as opposed to initially with a lot of hierarchy and there was not much of the communication. Next slide. Yes, findings from the B-Lynch procedure. Since the training, practitioners have been actually giving testimony that they have seen competence among them, and most of the surgeons have now reduced the number of subtotal hysterectomies for the cases which are unresponsive to medical management of PPH after vaginal birth or cesarean section. For example, in only 2 regions, we have, since training, we have our reports show that 57% of the B-Lynch procedures were done. Kagera region 33 and Mara region 24. And these are done at all level facilities, from health centers to the hospitals at the district level or the regional levels. The majority of the providers doing these procedures are non-specialist doctors, either medical officers or the assistant medical officers with advanced diploma. We see a success rate standing at 93%, and our data has not shown any complication like internal bowel herniations or gangrene of the uterus. Next slide. So in Tanzania, we think we have a good number of key lessons. One is that non-technical skills like teamwork, communication are essential to building team to improve performance. And the use of surgical safety checklist is an important patient safety tool, actually. And it quite improves surgical outcome. And in our context, it has actually built the culture of communication and consciousness on the patient safety during surgery compared to when we were starting this program. The B-Lynch is also an easy and effective procedure, as I said, and we have seen even the assistant medical officers, in fact, being more competent to do it without any problems, and has demonstrated improvement in surgical outcome, as I said. Next slide. A few challenges, some of these challenges have been noted that definitely our health management information system lacks data element for the PPH section. So it creates challenges in tracking PPH outcomes, and also TXA guideline was incorporated, developed, and disseminated, but more at the national level and maybe at the regional level. As we go down to the lower level facilities, health centers where we see most of these C-sections conducted, we didn't see availability and even awareness on the importance of TXA among providers. So this is an area which need to be addressed. But again, apart from the two regions where our Safe Child program has focused, we think we see that the B-Lynch compression suture for the unresponsive PPH, I think competence and skills is lacking among most of the providers. They probably have had it in the school, the training, but the practice, I think, is not as expected. And I think majority lacks the competence on how to do it because it's not integrated into continuous probably education, or not much incorporated in the pre-sales training as a skill to capture before we graduate. Next slide. So we recommend to improve availability of TXA and so that the quality of care for prevention can be improved and the management of PPH will be that way, I think, also improved. Again, introducing PPH data capture in the system for both vaginal birth and the C-section. We think also there is a need to strengthen skills among providers for the management of PPH, especially with this new approach like the B-Lynch compression sutures and integrated with other approaches. Again, strengthening practical skill of surgical management of PPH in the pre-sales training. I think the gap exists. Not all providers, especially in these low resource areas, the in-service training sometimes is not really reaching all the providers to the lower facility levels. And therefore, this update takes time to reach them. So if people could graduate with these skills, probably it will be a good chance for them to practice. Again, improvement in maternal and surgical outcome requires a multi-component intervention in the program. So it should be designed and implemented as a multi-component, not just as a project focusing on one intervention. And I think another, now from this, a question to note is that for the surgical management of PPH, as we train, we have been training and insisting on the use of the B-Lynch, we also see the practice for the prevention, where those at risk, for example, with the multiple birth and previous history of PPH, some practitioner recommends giving oxytocin and then misoprostol. Now we see TXA gaining more evidence and showing effectiveness. So the question problem which needs attention discussion from experts is how should this be combined? If you have TXA, then you have misoprostol. For the at risk, if you want to focus on the better anticipation and prevention, should we combine TXA and PPH? Does it show any evidence? Or should we trust more misoprostol than TXA on top of oxytocin? This question I will pose to the audience for further discussion as we proceed. Next slide, I think. Yeah, so thank you for listening. I think I'll hand over back to you, John, I think, for the next piece, yeah.
Yeah, great. Thanks, Leopold, for sharing the Tanzania experience. I think that's really interesting work that's being done there, and particularly like you know, you mentioned about the importance of the non-technical skills, so the teamwork and communication, as well as the anticipation and planning. The integration of the surgical safety checklist, I think, is really important, kind of across the board. But your effective integration of the Beeline suture is really interesting. Findings that we have, and especially that it's being used by non-specialists and being used effectively and without complications associated with that. So thank you very much. And take this time as well. I know that some people are putting some questions, some comments in the public chat. If that's meant for the general group to respond to, that's fine. If you want to have this brought to the panel or kind of addressed more formally, please raise your hand and we'll take those questions. We'll have you ask the question directly, as well as any comments from country experiences would be greatly appreciated. And that will come after this next session. So I want to now introduce Dr. Albert from Tanzania. He's the head department at Bugando Medical Center, a zonal referral hospital in Mwanza. He's going to talk about the experience from a tertiary level hospital in Tanzania. Dr. Albert, you're welcome. I need to find you and admit you.
Good morning, John, and everyone who is in the United States, but good afternoon to all colleagues of mine who are in East Africa, and I can see there are some people from Ethiopia. Thanks very much for the presentation by Dr. John and Dr. Leopold. Surely talking about PPH or postpartum hemorrhage is truly a very distressing experience for the obstetrician, but also not for the obstetrician only, but for any caregiver who is in the labor ward trying to deliver a woman as safe as possible. As John and Leopold have said it before, we have postpartum hemorrhage as one of our significant complications, and unfortunately in the low and middle income countries, it consumes a lot of health of our mothers. Now, I would want to share our experience in Bugando Medical Center. We do have PPH as any other center that is delivering women. And I'm not going to really go back to the definition of PPH, but what we usually do is I confer with what the previous speakers have said, that we use uterotonics, and we also have a room to use a surgical approach. And the common and the most favorite one around us, around Bugando here, is the B-Lynch. And I'm going to talk about it in a few minutes. So we have also the drug tranexamic acid or TXA. So all those three methods are used. To start with, when we were doing our services, or we're giving services to our patients, let me take you back to what really happened in before 2014. We used to have oxytocin and egometrin all together, and I think Dr. Tibia would remember that we were using it when we were doing our internships, internship before that period of time. So until 2014, when it disappeared from use and we went to use oxytocin only, then statistics or data shows that the incidence of postpartum hemorrhage went up. And before 2014, postpartum hemorrhage was not the #1 cause of maternal mortality. but then it came and took over. So last year, the Ministry of Health brought back and strongly encouraged the use of agrometry apart from oxytocin that was commonly used. And also it introduced the use of misoprostol. That was there, misoprostol was there, but it was not really routinely used. And you'll be surprised that most of our health care providers did not know that use of misoprostol could be also as effective as using other, is a medical method of preventing or managing postpartum hemorrhage. So with the help of USAID Boresha Afya, there was training to disseminate the new guidelines last year in November, December, if I'm not mistaken. And so from, I guess from January, we have ergometrin and misoprostol being encouraged to be used to prevent and also to manage patients with postpartum hemorrhage. Now, getting back to Bugando, we have tranexamic acid, we have misoprostol, we have, I'm not going to speak about tranexamic acid at this point, but we have misoprostol, and we have ergometrin and oxytocin. And the regimens that we are using is, as John said in the beginning, that whenever you think you have a case that will need, will develop a postpartum hemorrhage, then it starts during the cesarean section. We remember all of us who have been using the surgical safety checklist that the team discusses if there is any anticipation of excessive blood loss of more than 500 mils of blood. And if so, then the team led by either the surgeon or the anesthetist prepares for that. So you need to bring in all possible gadgets or things that you can use to prevent PPH, including you might be having oxytocin alone, but you can also bring in misoprostol, and it's best put sublingually, or there's also a method of using it buccal, and then the patient can be administered during cesarean section. This has helped, and everyone is happy around here because we have very few cases of postpartum hemorrhage for that matter. If you look at ergometrin, we are using ergometrin. The formulation that we have is 0.5 milligrams, and it's given either IV or IM, but caution is also taken when you have either a hypertensive patient or an anemic patient that needs to be delivered by cesarean section. So precautions should always be there. As long as surgical management of or prevention of PPH, we have B-Lynch, and let me give you some little or some few facts. In 2018, that was when we started safe surgery, and most of our staff here in the hospital had not been exposed to the technology of B-Lynch. So we had postpartum hemorrhages that resulted into 48 subtotal hysterectomies due to hemorrhage. But then in 2019, they decreased to 20. And as I'm speaking now in 2020, we've been required to do only 8 subtotal hysterectomies as a result of postpartum hemorrhage. And this is thanks to the practice of using B-Lynch. And if you ask yourself, like, what happened in 2019, we were few surgeons who would be able to do that. But when we had sensitized among ourselves, then more people and even our residents are now having skills to do the B-Lynch. And it has really helped and saved many women from getting to be done a subtotal hysterectomy. So B-Lynch is there. As you said, it's quick, and it's really very, very easy when you have mastered the skills. But for my colleagues who are maybe hearing it for the first time, don't be afraid, just be encouraged to learn. And it's really saving a lot of time during surgery, as compared to doing a subtotal hysterectomy. Tranexamic acid, yes, we have it in Bugando. I'm not really comparing our center with any other places. I know there are all challenges of getting tranexamic acid, but it's also a very helpful drug. We usually administer 1 gram IV when you want to achieve hemostasis after doing some other interventions. You might use oxytocics like oxytocin, misoprostol, and augmentin, but you can add tranexamic acid, and for us, we have not really had any problems with that. What else were we really using? Yeah, I've talked about tranexamic acid, and what I would say is there is another challenge that usually comes. You know, you might struggle a lot with a patient in theater, trying to help a patient who had postpartum hemorrhage, but then a challenge comes on the post-operative care. So at this point, I would want to emphasize that whenever you encounter such problems in theater and you manage them correctly, remember the patient will not heal from theater. She needs to go to the ward. And if she needs to go to the ward, our documentation of all the challenges and what should be done when the patient goes to the postnatal, post-operative wards for further care should be clear, and the surgeon or the team should really follow it up to make sure that what is desired for that patient is delivered or is provided to the patient to alleviate any further complications. So issues of getting blood, issues of continued medication, or maybe giving hematinics, or following up a patient should always be clear. And this goes to the way we document our postoperative notes, and also trying to communicate, because a nurse who is in the ward will not know what really happened in theater. So the only way to know what was happening in theater and what am I supposed to do in the ward is to just read what has been instructed by a colleague in theater. And if we do that one closely and with a lot of commitment, then we can also save our patients from getting complications after the surgery, the cesarean section, and after the patient has undergone or has experienced postpartum hemorrhage. So with that, probably if there are going to be any other comments or any other questions, maybe I'll be able to respond. But in short, that is our experience in Bugando Medical Center. Back to you, John. Thank you.
Okay. Thank you so much, Dr. Albert. It's always great hearing your experience. It's really valuable. But stay close by, because we may have some questions for you. So I'm going to open up to the question and answer, and also just discussion. So if you want to share your experiences, in the country, or if you have particular questions for the panel or anyone in particular, this is the time to do that. So please raise your hand, and we have them coming through both the public and the private. So we're going to start selecting those. I'm going to start with, I believe it's Rabil.
Hi everyone, thanks Dr. John for giving us time to share our experience in prevention and management of PPH with cesarean birth in Afghanistan. My name is Rabil. I'm a safe surgery advisor with Himayat project in Afghanistan. And Himayat is a 5-year USAID funded project led by GPIGO, which aims to increase utilization of high quality family planning and maternal and newborn health services through the introduction and scale of cultural appropriate, gender sensitive, cost-effective, high impact family planning and hemorrhage interventions. The project was due to end last year in 2019, but was extended and will now end in September 2020. Afghanistan has a fragile state since the last 4 decades, and health sector is also affected like other sectors, worsening security and COVID-19 pandemic as especially impact on the health of women and children. Maternal and newborn mortality are high. Based UN estimation in 2017, maternal mortality rate was 638 per 100,000 births in Afghanistan. And according to Afghan Health Service 2018, obstetric hemorrhage is a leading cause of maternal death, which is 27%. Using uterotonics for prevention of PPH is included in national policy. However, according to a national quality of maternal and newborn care study in 2016, although 19% of facility had uterotonics in the delivery room, and 23% of skilled birth attendants no active management third stage of labor, and 22% of women receive a uterotonic immediately after delivery, while 28% do not. 58% women were not checked for postpartum bleeding and consult on PPH danger signs before discharge, which there is a little difference between skilled birth attendants' knowledge and practice. According to an observational study which conducted by one of the senior obstetrician in Malala Maternity Hospital, which is one of the biggest and busiest hospital in the capital of country, observed 39,985 women and 140 pregnant women with PPH were in this the study subjects, and the overall polled incidence of PPH was 0.35%. The major cause of PPH in this study was return product of conception, which was 55.7%. 13.6% was uterine atony, 6.4% was uterine rupture, 16.4% was perineal laceration. The incidence of PPH after vaginal delivery was 97.8%, and the incidence of PPH after cesarean delivery was 2.1%. Hysterectomy was more frequent among women who had obstructed labor and uterine atony. 20% also require blood transfusion. In 5.7% of cases, benign suture was performed and maternal death was 7.1%. MOAT added safe surgery as a pilot program in 3 urban tertiary hospitals, Malala Maternity Hospital and Khair Khana in Kabul and Herat Maternity Hospital during the extension period of project. Due to this short implementation period, MOAT selected only one indicator, which is use of surgical safety checklist in cesarean section. We did not include complication of cesarean section because it needs more time and more budget. In the beginning of this program, we trained 50 obstetrician nurses, anesthesiologists, prepare a use of surgical safety checklist. Also, MOAT from the first year of project had focus in prevention and management of PPH in community and facility level, conducted comprehensive PPH trainings, provide PPH national package of competency-based performance, improvement learning tools and job aids in all MOAT coverage facilities. PPH protocol has been updated in line with WHO recommendations. Tranexamic acid was included in the PPH protocol, and a comprehensive PPH training package addressing PPH at community and facility level is in place. But we are not sure that the mentioned protocol is available in all health facilities in Afghanistan.
I'm sorry. This is, I really appreciate this. Is great information, and for sharing that. But I am mindful of the time, so I would like to if you can just wrap up in the next minutes or so, and then we can move on to others to be able to share their experience. Thank you.
Okay.
So you can finish. You can just summarize, and then we'll move on to the next person. Thank you.
In MOAT targeted health facilities, doctors and midwives are able to perform whole scope of practice, including manual removal of placenta, repair cervical tear by manual compression, balloon tamponade, but some gap remain, such as lack of detailed MNH process, quality and income indicators in HMIS. In summary, many components of the PPH framework are in place, but ensuring a quality of care and improve maternal health outcome in Afghanistan still need continuous support. And we recommended further investment for prevention and management of PPH cases in all over the country, and enable all health providers in management of PPH cases after birth. And the meantime, record keeping and the use of data for quality improvement is a vital part of the interventions, which need more focus and involving of the hospital management team as well.
Great. Okay. Thank you so much, Rabil. There's so much rich information and experiences that are coming out of Afghanistan, and it's great to see that the safe surgery is being integrated in that, and the lessons that we're starting to learn even from that short project. So I want to take this time now. I'm going to go to, if I could say your name correctly, Elamase from Malawi.
Yes, thank you very much. And thank you for the presentations and the experience that have been shared. I'll go to the experiences. For the guidelines, for certain sections, yes, we have guidelines, but going through the process, learning from this community of practice, we have that some which meant, let's say, for prevention of infections, they don't go further to talk about, for example, breeding foreign cesarean section. So they just talk about how to prevent infections. So we have noted that gap basically through the lessons that we're getting from this community of practice. We have protocols, obstetric protocols for management of postpartum hemorrhage. They too do not specify to say this bleeding is coming from the normal birth as well as from a cesarean birth. Again, this needs to be updated to show, because there is more to the management of bleeding that comes following the surgical birth. About the TXA, TXA is available in the country. Of course, largely it's being used for other surgical bleeding, but in the tertiary hospitals, they are using it for management of postpartum hemorrhage. So that gives us room to say, we already have like something working on the ground. Once we work on updating our protocols, for sure we will have it. Maybe what we'll have to work on is now how to have the medicine, the drug procured in the country, but to have it on the protocols, I'm sure we're going to have it. Because most of the gynae or obstetricians, they are working in these tertiary hospitals, and they might have seen already how TXA is important in managing postpartum hemorrhage. In terms of data capturing, I should say that our data tools, they do correct information about postpartum hemorrhage. Of course, it starts by saying the mode of delivery, the tool. So you say a spontaneous delivery or cesarean section, and then maybe as a complicated postpartum hemorrhage. But in our reports, the reports that are generated, they're not routinely segregating this data to say this is from the cesarean sections or this is from the normal deliveries. But if you want to make an analysis, you can go to the registers, you will find the information. But I think knowing how important breeding after cesarean sections is coming, I can just give an example. Like 2 days before, in two of those 5, they were from cesarean section. So it's really becoming important that we draw our attention to postpartum hemorrhage following cesarean section, because they died the same day that the CS was done, meaning that if we had done something better, they wouldn't have survived. Yeah, I think in line with the guidance that was given to us on how we can share our experiences, I think this covers it, unless there are questions. Thank you.
That covers it very well, Alamasi. Thank you so much. That was great, great to hear. Next, I'm going to go to Professor Falkus.
Hello. Yeah. Hi. I hope you can hear me all right. Thank you.
Yes,
I
yes.
just wanted to share a few things about South Africa. Hemorrhage is our 3rd most common cause of maternal death, and bleeding associated with cesarean is the biggest group of PPH. And we've been very concerned about it for a long time. And a lot of the PPHs happen at district hospital with non-specialist surgeons and anesthetics. And it's also there are not enough staff in theatre quite often. Sometimes the same doctor does the anesthetic as does the surgery. And the one scrub sister is also the surgical assistant, and the person giving an anesthetic has to look after the baby. And there's no one in recovery. So there is an issue of, I think, human resources. and we've tried to address that. I think the lesson, what we've done is, firstly, we've tried to get the anesthetics involved. So this isn't seen as an obstetric problem, because the person giving the anesthetic, who's hopefully different to the surgeon, is the one who has to resuscitate and administer all the medications. And they have to agree. We had problems where our anaesthetists were wanting to give very low doses of oxytocin, and our surgeons were wanting to give higher doses. So we needed to agree on an algorithm. We also developed a training program called ESMO, where we teach the B-Lynch, and we've got some training videos, but we do have a situation where there's no one in the district hospital who can do a hysterectomy, and this is only for a few cases, and there's no other hospital nearby, and so they have to refer the patient, and then she dies on the way. So for those kind of cases, we use something called the uterine tourniquet, which I think was developed in Zambia, where we tie a Foley's catheter around the uterus. It compresses the uterine arteries. We then close the abdomen and refer her to the next level of care, where hopefully she now arrives alive and has a hysterectomy. And then I think the third thing we looked at was we realized that there were lots of system issues. It's not just surgical, anesthetic, and teamwork. It's about the HR issues. How many doctors do you have in theatre? Do you have blood on site? And we developed some minimum standards. And in fact, I'm involved in many. We go around all the hospitals that offer cesarean section to see if they adhere to these standards and advise if they don't. And the blood transfusion service has been helpful. And we've also stocked all the district hospitals with something called fresh dried plasma, which is plasma in powdered form, which stays in a pharmacy for 2 years and can be reconstituted with water, sterile water, to make clotting factors. And then the other systems issue we kind of focused on is, what happens after she has the cesarean section? Because if someone bleeds in a postnatal ward, it's far too late. But if they can be picked up while they're still in theatre, but then some theatres in district hospitals don't have recovery areas. So again, our minimum standards emphasizes that someone must monitor the woman and she must be signed out before she leaves the theatre suite. And then the final issue I think that has to be addressed in poorly resourced countries is the issue of referral, because if the surgeon and anaesthetist have done all possible they can to stop the bleeding and they still can't, and no one is around with the skill to do the hysterectomy, then you've got to think of how you transfer her so that she arrives alive. As I say, one thing is this uterine tourniquet, and the other could be the use of the anti-shock garment, because we were also concerned as to how many people were dying on the way from one hospital to another, and how slow or unconfident non-specialist surgeons are if someone bleeds after a cesarean section to reopen her, because maybe they can't do a general anesthetic, she had a spinal. So they're kind of, I would say, I think one's got to look at the systems issues, the referral issues, as well as the sort of technical teamwork issues. Thanks.
Great, thanks, Professor. A lot to digest there, and agree with it. Those points about the systems issues are certainly important. We have just about 5 minutes left, so I'm going to go quickly. We have 2 more hands that are raised, and so I'll go to Bento and then Daisy. And if you, I'm sorry with the time crunch, if we could just limit it to about 2 minutes each, and then we'll wrap up. So I'm going to go to Bento first.
Thank you so much, John. So we are just grateful to be part of this very important lesson learning experience sharing forum. So like other countries, we are still struggling with PPH in our country. And I think if not everyone on the call, many of you may know that currently the maternal mortality ratio is at 1072, that's 1,072 per 100,000 live births, and then neonatal death is at 26 per 1,000. However, there are a lot of efforts that have been made. Right now, the key causes of death for mothers are 3 main causes, where PPH are taking the lead. I was very glad when I saw the B-Lynch, the presentation on B-Lynch. This is one of the methods that we use in Liberia, and like my colleague just said, but we don't have a lot of doctors who are okran with B-Lynch, and we are trying to see how we can have some of these people. Again, we right now on our reproductive essential medicine list, we are using oxytocin and misoprostol to manage PPH, and so we are also looking forward to reviewing and updating our existing PPH protocol. So we are also contemplating on including the tranexamic assay, but we are looking forward to learning lessons from countries that are already using this, and the evidence will help us to decide the inclusion. We are also in Liberia looking at the team approach. Although we don't have it widely, geographically spread widely, but we are working towards it. We have MCR that's working with us and training, doing this tax sharing training, because we, in this part of our country, we don't have the luxury of a lot of doctors who will be in the rural areas to actually do these critical procedures as it relates to obstetric complications. So right now in the country, we've embarked on the team approach, which is now geographically spread widely, but we've started. And we are training OB clinicians that are working alongside with the doctors in the rural areas. And we also have the nurse anesthetic training going on, but the numbers that have been trained are so little. So we try to see how we can accelerate that so that we have the numbers that we need. Though we may not have the numbers in a near future, but at least we can work towards that. Another thing that we are also looking at is the issue of the referral, because like the previous speaker said, you may have all the experts, but if referral is delayed based on all the kind of challenges that influence prompt referral, we may not go very far. So we are also working on the issue of referral, making sure you have trained nurses and midwives on the ambulance, and trying to see where we can have ambulance situated at CMOR facilities and some critical BMOR facility, so that we cut down the distance, because the roads are not the best. So these are the things that we are doing, and we are looking forward to learning from countries that have some evidence-based intervention that we can also consider in our endeavors. Thank you so much for inviting me on this.
Great, thank you so much, Bento, for sharing that. And I know people are dropping off, very quickly, and I'm still going to go to Daisy, but I just want to catch people. Some that have to drop off. Is that one? Want to thank you so much for coming to the session, and we will be continuing the dialogue. We'll share the PDF of this, and we also have a recording that will be on the website. And the questions that we didn't get to, we'll provide a summary of the kind of the key points to this, as well as questions that we did not get to. So I wanted to turn to Daisy. We'll just take a couple more minutes, and then we'll be wrapping up, because I know others have to get off and get to other meetings. But Daisy, you've been waiting patiently. Welcome.
Yeah, sure, John. Thank you very much. Thank you to the Tanzania team for sharing your experience, and everyone else who has shared. Because of the interest of time, allow me to just share one other thing that the rest of the team did not share. And just to say, in Kenya, we are currently revising our guidelines. And within these guidelines, we are including a new uterotonic into the basket of the uterotonics. This is the heat-stable carbetocin. We are including the TXA. We also are including the shock index, possibly going to include the surgical safety checklist, as well as the maternal early warning signs system or criteria. So just to say that, to add on to what everyone has mentioned in terms of the medical management, is that for Kenya, as a result of that WHO recommendation, we have now had a chance to include heat-stable carbetocin into the guidelines and the protocols. And I am working in a project that will be supporting the Ministry of Health in terms of really reducing maternal mortality associated with PPH. Within this project, then we will be introducing an innovation, which is the heat-stable carbetocin. As we all know, and as the name suggests, this will really be very useful in really addressing some of those cold chain challenges and the quality of oxytocin as a result of that. So just as a background is that Kenya has registered this drug. It is already in use in the private sector and some of the big public referral hospitals. But what we are looking at doing is then making sure this gets rolled out to the public sector so that they have access. One key thing to note for Kenya is that unlike Tanzania, we do not use igometrin that widely. The main drug is oxytocin, and we do also use misoprostol. So, sorry. So, yeah, this will be the new addition that I didn't hear anyone really mention, but we are looking forward to supporting this and having this rolled out as part of the uterotonics in the public sector. Just to mention, like Tanzania team has said, we do have the same workforce challenges. We do have challenges with the non-specialist providers, with the challenges with skills. And currently the country is working on a lot in terms of pre-service to make sure that these teams are prepared way before they are released out to the facilities. While the in-service also continue as Tanzania has mentioned. In Kenya, we do have PPH data up to the HMIS level. And hearing my colleague from Malawi, maybe the challenge might be that the data is not segregated into vaginal delivery or PPH, but we do have the data. And if we wish to really, segregate that, then we can go back to the source documents. Back to you, John. I just wanted to mention that we do have an additional as carbetocin for the uterotonics. Thank you.
No, that's great, and I knew that you guys are introducing that. Thanks again, everyone. I know we've gone over, and Geeta, I'm sorry we didn't get to you, but I know you wanted to talk a bit about the anti-shock garments, and that's more about kind of temporization and referral, and maybe we can include that in the meeting notes if we can get some information on your experiences with that. So I just want to summarize, this has been, again, a great conversation. It's clear that we can go much longer on this. There's a lot of issues to cover, from guidelines, from developing guidelines, implementing guidelines, the availability of TXA, not only in a guideline, but actually the availability in the medical stores and then at the facility level, which also gets at that whole systems issue. When we were talking about system readiness and organizational preparedness, I think is really important. We talked about the workforce density issues and the challenges around that, and some of that is looking at the task shifting as well, and I think that's where the B Lynch does try to come in to handle that. So we're not referring patients that are very sick and have difficulty in making that referral that end up requiring some total hysterectomy because they weren't managed at the lower level facility, and also the issue around obviously blood, and that was also one of the special topics. One of the lead issues that was raised during the PPH community practice annual meeting, and I think that's going to be focus of a future special topic deep dive. So I think we can look forward to that. And the last thing I want to mention is about the data, because I do think that we need data for us to inform what we're doing, and not only is it an issue around disaggregation, which I think is really important. It's difficult to go back to source documents, but if there's a way of doing that in real time, disaggregating it. But I think it's also the reporting of it. I think Afghanistan reported. Ruby was sharing. I think it was less than 1% PPH, and we know that that's underreporting. So we see this in across countries. So improving the capture of that data is certainly going to help us go forward. So I know we're well over time, but again, a huge thanks. I really appreciate the interest, the engagement of people for this. A big thanks to the Tanzania team for sharing your experience. It's really helpful to kind of set the stage, and for all the other countries for participating and sharing that experience. We will be, like I said, we'll have the PDF of this presentation available, the recording, and we'll summarize notes and try to address the questions that were that we did not get to in the chat. So thank you, everyone, and we'll stay in touch, and I look forward to future deep dives. Thank you.
Thank you, John. Thank you, everyone.
Bye.